Hi, I'm Tif Qureshi, and this webinar is called The Lifetime Patient. I've had a history in cosmetic dentistry, but ultimately I'm a general dentist. Most importantly on this slide is just to announce that I'm one of the owners of IAS Academy, so that's my disclosure done with. And also, of course, if you're interested in Facebook or Instagram, you can connect with me on there. So what are we talking about? We're talking about the lifetime considerations for patients and strategies that ultimately I'm hoping will allow you to see how I treat patients and how to look after these patients over a much longer period of time using ortho-restorative dentistry. So we're going to break it up into several sections. Part one is talking about how ortho and occlusion are actually linked more than perhaps we realise. We will also talk about how teeth continually move and how that really does change our perception of dentistry and looking at things long term. Of course, we'll talk about ortho, how you should plan for ortho and how you should control those movements. I'll show you plenty of cases looking at intercepting treatments, intercepting dentistry, stopping patients' teeth getting worse and setting their teeth up for much longer periods of time and stability. And I'm going to give you sort of 5 main aims that every general dentist can do as part of this treatment. And of course, this is a small part of our 2-day Align, Bleach and Bond program. So, the first question I'm going to ask you here is, how often do you see patients with teeth like this? Many patients have every day, you'll see them with chipping front edges, composites repeatedly failing, exposed dentin, crowns, or perhaps teeth eventually ending up needing crowns. And I'm going to ask you that question and just leave that question with you. How many patients do you see with teeth like this? I would guess most dentists will have thousands of patients in their practice with teeth like this, and just keep that in your mind. Now, the next question I'm going to ask you here is, do you want to do aesthetic and cosmetic dentistry for the right reasons? Well, what does that mean? Of course, there's nothing wrong with treating patients who want aesthetic and cosmetic dentistry, nothing wrong with that. But sometimes I believe patients kind of are sold into treatments. Maybe they have treatments, but they don't really understand the functional benefits. So guess what I'm trying to say here is, wouldn't it be nicer if patients who decided to have aesthetic and cosmetic dentistry really understood the functional benefits and the potential lifetime benefits of those treatments? And this leads into my next question. What does it mean to treat a patient over a lifetime? Well, are we as dentists just doing a treatment for a patient to make them happy and then say goodbye? Or are we doing a treatment which actually could provide that patient a much longer term stable functional situation? Meaning, if you do some ortho, you do some bonding, you're doing it not just to make their teeth look better, but actually provide that patient a better long-term functional stable scenario. You also will develop the relationship with patients rather than just potentially focusing on seeing new patients all the time. And actually, treating patients who you know is undoubtedly safer than treating patients you don't know. This is where the logic comes from. So Align, Bleach and Bond is far more than just aesthetic treatment. Of course, it has to be aesthetic. We want to have a good aesthetic outcome, and this patient goes through the alignment process and edge bonding process to get the smile she wants. But if I go back one step and you look at the position of those two centrals, you will see those teeth are retroclined. And the reality here is, if you just place veneers on those teeth, you're not dealing with the issue that those teeth are retroclined. They have a limited amount of space. They have a constricted envelope, which we will come to later on in the presentation. So ultimately, you're not solving that patient's problem. By aligning the teeth, we're giving the patient a correct overjet, and then by edge bonding the teeth, we can now ensure that when the patient slides her teeth forward, she gets proper posterior disclusion on her anterior slide. So it can absolutely be a functional treatment too. And the question we've got to ask ourselves are we going to allow patients' teeth to go from minor wear to severe wear and lots more chipping? In fact, actually, but in this particular case you're looking at, the patient at the top of the screen is the daughter, the patient at the bottom of the screen is the mother. The daughter's 24, the mother's 58, and the question here is, who's in more trouble? Arguably the daughter is, because for 24 years old, that's a severe amount of wear. And the reality is are we prepared to just leave this and say nothing to the patient, knowing that that dentine exposure is going to get worse? The teeth are potentially going to crowd more. The truth is we should have the ability, through a little bit of alignment, a bit of bleaching, a little bit of edge bonding, just to set the teeth up correctly. And what that means is in a patient in my practice who has this sort of treatment does, I know for 100% certainty if that patient comes back and sees me regularly, they will never end up like the patient at the bottom, like them as the mother's teeth are. Meaning you can prevent your patients ever needing rehabs. That's ultimately what we're aiming to do. Here she is now. I mean, her teeth aren't bad, but she's got increased crowding, her bite is deepening, and the goal of doing this treatment is through some ortho and bleaching and ultimately ortho and bonding, we can actually slightly increase that vertical, reverse that dental collapse that she'd suffered with, and improve her anterior guidance as well. We're not aiming to achieve perfection if the patient doesn't want perfection, but we can massively reverse that sort of dental collapse, which can lead to further problems later on down the line. I noticed this whole process by doing treatments and fundamentally then following those patients up again and again. When I treated this patient about 15 years ago, I wasn't really thinking so much about the function. I was thinking about just giving her straight teeth. And we gave her straight teeth and she was happy. And it occurred really quickly and it was done with an Inman aligner. And you know what, we thought that was great. But what was much more interesting was seeing this patient again after 1 year, 2 years, 5 years, and 10 years. And I noticed a few things happened. I noticed when I saw her, again and again, that a lot of the initial problems that she had weren't getting worse. Now, what were those problems? Well, actually, at 21 years old, as you see on the right side of the screen, she has a lot of tooth wear. She has a lot of dentine exposure. And I noticed that as we started to align the teeth and we held the teeth in those positions, and then I saw the patient again and again and again over sort of 7 years and 10 years, that actually the relative amount of wear on some of those teeth hadn't increased. We also had given that patient her canine guidance back because she was actually slipping out of canine guidance. So these things can provide long-term functional benefits if they are set up correctly and also if you are monitoring the case. And I noticed that this would repeat itself again and again. So patients who used to have chipping teeth and bits breaking off, we'd straighten their teeth, we'd obviously whiten them anyway, and then edge bond their teeth. And then when I saw the patients after 3 years and 5 years and 10 years, it's surprising how much of the edge bonding would stay and would remain. It also values, the importance of long-term care. The importance of long-term care is that you can intercept problems. So I did some ortho on this patient, many years ago. I think it's like 10 or 11 years ago. This case, we aligned his teeth, we changed the crown, we did a bit of bonding, and I saw him every year. And every year I saw him, I would check his retainer. And at year 5, between his upper right central and upper right lateral, his wire started to fail and started to break. So I repaired it at that point. And here we are 2 years on, and this case is nearly sort of another 5 years on. It's about 10 years old, and that retainer is still there. So it's very, very important that if you are going to do these sort of interceptive, restorative orthodontic treatments, that you do have an intention to look after that case. And if you do, you can probably provide that patient with a much better long-term outcome, which is what we want. So my long-term sort of functional strategy, which I'll touch on a little bit later in the presentation, is ultimately to prevent patients going down this sort of slide. And most of the cases I'm trying to treat are a type 1, type 2, or type 3. And type 1 could just be changing the patient's anterior guidance to help sort of protect wear facets developing, protecting anterior tooth surface loss as well. Type 2 might be a little bit of ortho and a little bit of bonding to improve the guidance and function. Type 3, I will often consider that involves increase in the vertical, which might be through Dahl, it might be through ortho and bonding as well, and to try and improve function. And ultimately my goal is to prevent the patient ever needing a full mouth rehab. That's what I want to try and stop, is a full mouth rehab. And I would argue that no patient who sees a dentist regularly ever should need a full mouth rehab. And the fact they do is as a result of not enough dentists having and employing this strategy. So what we're trying to do, as I say, is prevent these not necessarily connected problems, but they are commonly connected, where slow anterior crowding, constricting envelopes, which I'm going to define, increasing tooth wear, loss of vertebral dimension, loss of anterior guidance. All of this is part of an aesthetic and functional breakdown, which, you could call that just aging, of course, but the reality is that it's actually very preventable. And when patients get to a certain point, if you leave it too long, fixing this problem can become very expensive. So if we can prevent it getting there, we're saving the patient a lot of pain and a lot of cost down the line. So it's really important to understand what to say. And a little later on, I'm going to touch on how you monitor these cases. So this case that I've seen for a while, and I'm then going to talk to this patient about what's going to happen to her teeth by explain to this patient about the sort of slow minor tooth positional changes, the functional changes, and helping this patient become very co-educated with what is going on. I would expect this patient in probably 2 or 3 years' time to walk into my practice and say to me, Tif, can you please fix this problem? I can see this tooth is moving. I can feel this changing pressure on my teeth. And I think you were right with what you were saying. This is what I meant about doing cosmetic and aesthetic dentistry for the right reason. I'd much rather have a patient come to me and say, I understand the benefit of what you're doing and providing, and therefore I would like to have it done, rather than me trying to sell them something based on how it's going to look. Not that that's wrong, but ultimately I think we are missing patients, all the patients sitting in our chair with teeth like this. And this whole approach, combined with things like the Dahl principle, can mean that you can really help to minimize the amount of damage long-term to cases. So this patient in 2004, I did some Dahl build-ups on her lower teeth. We did some upper ceramic units. We replaced a bridge as well, which she needed doing. And then in 2019, you can see on the top right of the screen that composite started wearing. We stripped it off and we replaced that composite. So I know for sure this patient, if she keeps coming to see me regularly, will never end up needing anything complicated on her lower teeth for sure. And ultimately, this whole concept of prevention and aesthetics is actually to provide patients with something which, yes, it looks great, but it isn't going to get worse. And so this case, which may just look like an ortho crowding case, actually is quite functional. She has, in between her two upper centrals on the most mesial aspect, she has a constricting envelope. She has a V shape, which you often see, the inverted V. So if we leave this will get worse. If we align them, bleach obviously an edge bond, we can position these teeth correctly. So ultimately we can provide an improved functional outcome with improved aesthetics at the same time, which really is, for me, my gold standard. So these strategies allow what I call a lifetime approach to patient care, meaning you are moving teeth to a correct position to ensure there's no further tooth wear, to reduce the amount of deepening of the bite, all the things that ultimately can cause further problems, further aesthetic and further functional problems down the line. And we're going to now talk about what those individual components actually are and what they mean. And I'd also add that most of the treatments I carry out are not carried out on new patients. Most of the treatments I carry out are carried out on patients that I know that I've been speaking to for 3 months, 6 months, 1 year, 2 years, because I've been educating them, and this is what we're going to talk about today. So, one thing that's really, really important is that we need to assess our ortho correctly, and we must consent our patients. So this is my first time. If you're going to do some ortho, and bear in mind, not every case requires ortho, but if you're going to do a little bit of anterior ortho, it's really important to do the assessment correctly and consent your patient properly, and also use something we call the landmark tooth concept. So when we do ortho, we must take a full series of photographs, not just 8 photographs that the aligner company want you to make. You need a full series of photographs. We have to also carry out a full orthodontic assessment. We're going to create a list of problems. We're going to think about these treatment options the patient has. There's opportunities, obviously, to be mentored, and I'll talk about that a little bit later. You discuss the management with your mentor, or and obviously with the patient as well, and then you can decide whether you're going to execute or refer the case. The full assessment is critical, though. When we're doing orthodontics, we are not just moving teeth. the movement of the teeth to technically a correct position can also have an influence on the face and the facial features and the soft tissue and the facial profile. So these things are really, really important. And what we're trying to say here is you need to be able to assess a patient to the full standard of a specialist, exactly the same way a specialist would. And if the patient is a class 2 molar, class 2 canine, if your anterior alignment is not going to fix that, it's just fixing that anterior alignment, the patient must know that your treatment is a compromise and must also know that the gold standard treatment would be perhaps referral to get that treated to class 1. We must not fool our patients into thinking that what we're providing for them is ultimately the gold standard. It may be an acceptable compromise, but we must record down all the information. So ultimately, every single assessment form will have a few parts that are really important. One part is going to be the case summary. So if you've done ortho, you've been using an aligner system, it's so important that you must have a case summary which will cover the skeletal profile, the mandibular plane angle, face height, facial symmetry, soft tissues, incisor relationship, canine relationship, molar. All these things must be written down, because when you can see your case summary, it then helps you understand what the ideal aim would be. And in this particular case, the ideal aim would be to potentially, correct that class 2 molar relationship to class 1, and that may be something you can't do, and you have to refer for that. But if the patient has a reasonably stable, well-aligned posterior arch and they are class 2, it may be perfectly acceptable to accept the class 2, just align those anterior teeth with the patient's understanding that they're having a compromised plan. So that's really what we must do. And in our course programs, obviously we spend more time discussing that and explaining how to diagnose this and to differentiate it for the patient as well. Impression taken, really important as well. You're going to be taking probably impressions for aligners or using a scanner. The simplest thing I'd say is, never take alginates for aligners. Always use a good quality silicone impression, preferably 2-stage. And as I say, most scanner systems are good enough for aligners nowadays. We must also look at landmark teeth, and the landmark tooth is commonly defined as a tooth which is currently positioned correctly. I tend to look at these views, and what I'm trying to do is to gauge an idea on which tooth is corrected is positioned in the right sort of buccal lingual plane. Some teeth look straight, but they're actually too facial. They may be too lingual. Now, why we want that is we want to try and potentially maintain that point, so that when the teeth are aligned, we don't risk flaring them all, or we don't risk over contracting them. If you don't look at these images, look at the face, look at the lips, you can't tell that. So the landmark tooth is very, very important, or the reference point we may call it as well. So what I'm saying here is that we can't tell with this view, because with the front view or with the retracted view, it's very difficult to get a 3D kind of image. It's much easier to tell where the landmark tooth or landmark position could be from these views. And in this particular case, the patient felt his upper right central was probably close to the one that he wanted to keep the same in this setup. Won't go into this too much, but ultimately with IAS we tend to have a system where we are very, very into refined occlusal control. So what this means is that all the points you see with X on them ultimately dictate a curve, and what they are saying and telling our technicians are that those points need to remain the same, but ultimately the teeth are going to move to the line. The points of the teeth that aren't on the curve will move to the line. This allows us to check the overjet remains the same, so we have a good point where the overjet is correct. Then we can make sure that when the digital setup is done, the technician doesn't flare the tooth or over contract the tooth. It also gives us a rough calculation on the amount of space that we make, and this is something I do on every single ortho case before I even start any sort of impressions or anything, just to give myself an idea of what I'm planning on doing. And if you do take an impression or take a scan and I send this to the lab will do a digital setup, and then I will check from this setup and make sure that upper right central has not moved buccally or lingually. If they have, I'll then send it back and get them to do a new setup. This way I can make sure my overjet relative to the lower, therefore the amount of space is correct as well. And with IAS cases, you can do this, and you can also validate this because you're always going to receive 3D printed models, which are a great way of checking that you are getting what you've asked for. They're a great way of consenting the patient again. So you can show a patient who isn't class 2 what that actually means by putting the models, who isn't a class 1, what that means by putting their models in their hand and making them understand what a class 1 treatment may have provided. And you may be thinking, is that good? Do I want to put the patient off? Well, the truth is you need to tell the truth, and you must reveal everything that you are doing and everything you are not doing to the patient to really consent them correctly. And it's the right thing to do. Other things that we can do during our examination is just look at tooth width variance. Won't talk about this too much, but this is a very subtle art. And if you understand this and you apply this correctly from the beginning, you can create far more beautiful results. If you just blindly take a scan of the teeth and you send it off to the technicians, they're not necessarily going to distribute the space correctly. And also tooth shaping is something which may need doing even before you take a scan. This is something we talk about on our program quite a bit. I shaped these teeth a little bit before we started this case, and I made sure that by the end of the treatment that the tooth widths were actually more equal. So this is something we call PPR. And basically it then meant that when the teeth are lined, they look more upright, they have flatter connectors, they don't look unaesthetic, and they don't get black triangle as well. So these are little things that you can do to really refine your ortho aesthetics. Aim 2. As dentists, let's think about ortho, occlusion and function together as one thing, not as separate things. And I think that's always been a problem in this area. I believe that this situation occurs all over the world where general dentists do restorative dentistry and orthodontics do orthodontics. And that's it. And there's not much crossover. But the reality is, I believe this picture that you see is actually damaging patients all the way around the world. And I'm going to show you why. So the concept of ortho-restorative dentistry is different to perhaps what people used to think it was. People used to think it meant that somebody did a whole load of ortho, and then you came on afterwards and did a whole load of crowns or restorative dentistry. That's not what ortho-restorative dentistry means to me. Ortho-restorative dentistry is about everyday dentistry. It actually is something every dentist should be able to do. It applies to every patient at some point during their life, and it can be involved in every single checkup that you do as well. A couple of rules as well. I think important to get some rules right. Occlusion. This is not a big lecture on occlusion, but there's a few things rules that I stick to when I'm doing orthodontics and when I'm doing restorative dentistry. And I think that these Christensen and Ruiz rules have worked really well for me. Number 1, we want ultimately to have bilateral and even occlusal contacts for proper load distribution and stable occlusion. That makes sense. What I don't want to do is to treat somebody who has this situation and then leave them biting on 2 teeth. Yeah, that's fairly straightforward. Number 2, very important, we want posterior tooth disclusion through anterior and canine guidance. So this means that when we bite on our back teeth, we slide our teeth forward, our front teeth will touch and the back teeth separate. Canine guidance, of course, means we bite together and our teeth move left to right, our canines disclude and separate the teeth. Some people believe you don't need canine guidance, and I think you can manage without canine guidance. But I believe if you're doing ortho and anterior bonding, you have every possibility to give the patient canine guidance. And ultimately, the science shows that if that happens, particularly the anterior movement, there's decreased muscle activity as well, which can only be a good thing. And then finally, and this is very, very important, and I've touched on this concept, is that we want an unobstructed envelope of function, because when the jaw is moving around and chewing, moving laterally and protrusively, and returns to its centric stop, the right amount of overjet allows this movement to occur without interference, and interference is the key. Okay, so this slide will help us understand that. Envelope of function has to be credited, of course, to the great Pete Dawson, who came up with this concept, and ultimately what it is, it's described as the pathway the lower incisors will take as they move through their functional movements, and your tooth anatomy should be in harmony with the envelope of function. The overjet is very, very important. 2 millimeter overjet is very important for the envelope of function, and the tooth angulation should also be important for the envelope of function. What we don't want is to have these teeth colliding as they're moving around through their sort of functional pathway. So as I said, teeth should be in the right position, and here's the other key, also stable, not slowly moving. So let's think about a case, and here's a patient who walks in with complaining that her front upper teeth have chipped 6-7 times over the last few years. She says, every time the dentist puts a filling on the teeth, within a few months it's chipped away. Now my question to you here is, when a filling keeps chipping away on a tooth again and again and again, what do most dentists do? Now, you may say, I'm going to, give the patient a splint, I'm going to assess the occlusion, I'm going to do this, I'm going to do that. That's fine. But what happens around the world with most cases when teeth keep chipping, I don't think it's unfair to say that that tooth may end up with a veneer or potentially a crown. I think that's an answer which has certainly been said in many audiences that I've spoken to around the world. Now, keep that patient in your mind, because we're going to come back to that patient. What I'm going to talk about now is the concept of little study, because I believe when you apply little study to that case, you start to understand why that tooth kept chipping. I believe restorative dentistry all around the world has missed out little study in its focus on what is important for restorative stability. So let's look at little study and what it means. Little study tells us a couple of things. It tells us, when you look at the data and look at the long-term reviews and what they did, two things. One, very obvious, that ortho-treated cases need retainers because ultimately the teeth will keep moving. And this isn't a huge shock, but the next point is really, really important for restorative dentistry. It also tells us that even if you don't have ortho, even if you had no ortho at all, if your teeth are crowded mild or moderately, your teeth will keep moving at the same rate as a patient who had orthodontics but doesn't wear a retainer. Now, this is actually critical. It's actually ground shaking in restorative dentistry, and it's so important that every dentist understands that. Ultimately, the whole concept of tooth relapse is actually a red herring. It should be called continued tooth movement. And I often sometimes describe this continued tooth movement to my patients. I say your teeth are like tectonic plates, hence that title, dental tectonics, that your teeth will keep moving and colliding, and one will move forward, one will move back, as has happened here. Two main movements commonly occur. Collapse of arch width, often defined from canine to canine. As canines collapse, well, the incisors aren't going to narrow. They're just going to move forwards, backwards, upwards, down, and they're going to start to collide with the opposing teeth. The other movement that will often occur is collapse of arch length. So from front to back, regardless of whether you've got wisdom teeth, regardless of whether you've even got molar teeth, in many patients that will keep happening through their lifetime. Now, how did I see this? Well, I read some data on this years ago, but I actually realized before I read the data by looking at photographs of my patients. And take this patient, for example. Have a look at the lower two central teeth and the relative position, and you will see how over 3 years, watch right now, how 3 years of movement, this can actually cause the teeth to move. The crowding has caused the teeth to move, and of course, that lower tooth moving forward can start to knock against the upper and therefore constrict that envelope of function. Here's a case with, again, no treatment provided, and you can see over 4 years, just watch how much movement's occurred and the relative potential wear that's occurred from that movement as well. Again, we only see this by taking photographs. I think one of my biggest criticism of dentistry generally is that we are not taught or conditioned to take photographs often enough, so therefore we don't actually see this problem. This case provided by a good friend of mine in Norway. He also is looking at all of these concepts. Again, no treatment carried out on this anterior region, but again, if you look at over 3 years, you can see how His gap is closed. Obviously, he's had a little bit of soft tissue surgery on the upper left side, but the gap is closed. And if we actually look at some anterior shots with the mouth open, if you look at the overlap of those lower incisor teeth, you'll see how over 3 years that movement the movement's also probably causing a constricted envelope, which is causing a bit more chipping and a bit more wear on the edges of those teeth. That's only 3 years. Think about what 30 years would do to this patient. And all you need to do is perhaps give the patient a retainer to prevent a lot of these problems. It's very important to think about this. Here's another example of continued movement and the problems it can cause. This lower central incisor on this patient that's sticking forward, this is actually a post-ortho relapse, believe it or not. And just watch what this lower central tooth does to this upper central tooth. The video should play, hopefully. There we go, it's just playing. Watch it in slow motion. You can see how the lower tooth has drifted forward, and now when the patient occludes, that constricted envelope isn't causing tooth chipping, it's actually causing tooth movement. So this is just, we commonly describe it as fremitus, so it can really thump that tooth forward. And of course, that can result in bone loss over a period of time for a patient. So again, really important that we are looking at these things over time and educating our patients as well. This is just another example, a 7-year movement on these lower incisors, and you can see how they get thumped forward. Obviously, there's some occlusal issues going on there as well, but you can see how much they've drifted out. This is where the patient is more recently, with the lower teeth sort of drifting forward and a little space opening up. And this case was one that I treated in 2009. I did just some veneers on the patient's laterals, no prep, and some edge bonding. And watch what happens over 4 years, and you'll see suddenly a space opens up between her central teeth. Now, her upper centrals seem to just drift forward. And at this time, I was already aware that this was going on, and I felt ridiculous, and I felt crazy. I felt stupid. I thought, I should have realised, I should have noticed, but I hadn't been getting this patient regularly back enough to see it. And when I looked at her lower teeth, you look very carefully at the overlap between the two lower incisors, centrals, you'll watch how over about 4.5 years, that lower central has just nudged forward. That is causing a constricting envelope of function, which is pushing the two upper centrals forward and opening the space. That's not disastrous, but for the amount of money the patient paid for this case, that's not good. And really, at this point in 2009, here, I should have said to the patient, listen, either we're going to align the teeth and retain them, or number 2, we're going to retain them, or number 3, and I do say this to patients, if you choose not to align or retain your lower teeth, I don't mind fixing your upper teeth, but I'm not giving you any guarantee at all. I think that's fair, and I say that quite commonly, because you can't force the patients to have ortho on the lower, and you can't force the patients to wear a retainer, but they need to understand the risks involved. This is just an example of a case that I treated back in 2004. At this point, I'd done some edge bonding for her, but my mistake here was not to see her again. So I treated her and then she went away, and I didn't do any follow-ups on her because it was just an edge bonding cosmetic case. And you'll see over 15 years how much tooth movement there's been. You'll see the lower anteriors have actually shifted forward. Gaps opened up between the upper centrals. Some of the edge bond, the edge bonding is still there on the uppers, which is pretty good. But if you look at from this angle particularly, you'll see how those lowers have sort of drifted forward. The space has opened up between the 3 and the 4, and that's caused a constricting envelope to nudge the upper centrals forward. So loads of these cases I have collected over the years, but they're very, very powerful, and they fit perfectly with little study. And now, finally, possibly my most embarrassing case. You're only going to see the latest picture, but what I will explain to you is this particular case I treated in the year 2000, and I did 8 upper and 8 lower veneers on this guy, and when I've treated his case, his teeth were perfectly straight with the veneers that I'd made. So his teeth were a little bit crooked, and I made his teeth straight with the veneers, and this is how he presented 17 years later. So if you look on the right side of the screen, his teeth, just so that you know, are as crooked as they were when I veneered them 17 years ago, and what all that's happened is they've moved back to the same position and possibly got even worse. So it's pretty horrifying for me to see this, but it's also a very good lesson for us to understand that if we are going to do veneers or crowns on teeth that are not optimally positioned, they are going to move. And this is the thing, were we retaining cases that had crowding? Well, back in those days I wasn't, because I didn't know. What if the patient decides they suddenly want to have ortho done later and you've done veneers on their teeth? You're stuck. And another question is, why do anterior composites chip so much? Well, look at his lower centrals. They're made of ceramic and they've chipped. They've chipped because those lower centrals have drifted forward into that constricting envelope of function. And that's why they've chipped. And here's the most important question. When we're doing veneers and crowns on patients' teeth, often dentists say, oh, I did veneers because the patient didn't want to have ortho. Well, you know what? That's an interesting question, but it's irrelevant. The relevant question is that you should say to your patient is, that's fine, but will you wear a retainer? Because you know what happens when you tell the patient that? Most patients say, why do I need a retainer if I'm having veneers? What you then say is, because your teeth will keep moving anyway. And I promise you, 9 times out of 10 at that point, most patients say to me now, really? In that case, I think I'm just going to have the orthodontics done. So what we're looking at here, I believe, is actually a global problem that is out there where patients don't really understand why they're having the treatment done. So it's really, really important that we are telling the patients the facts and we don't just jump straight into doing veneers and crowns. Let them understand that their teeth are going to move and then let them decide about whether they need ortho or not. Aim 3. So here's the thing. Let's not just crown or veneer teeth without considering these changing envelopes, because it really can change the way you look at every single anterior case you ever treat once you start looking at this. So we're going to go back to this case. And the question here now is, what should we actually do with this lady? Remember the lady with the repeatedly chipping front tooth or front teeth? Now, the reality here is that treatment is actually completely pointless without ortho, because the teeth are always moving. If you put a little bit of filling on her front teeth, you might make it look perfect. You might perfect the occlusion now, but in 3 to 6 months, those upper centrals probably will start to drift backwards a little bit. The lowers might crowd forwards a little bit. Constricting envelope, pow, composites broken. That's what's actually happening here. So here she is from her initial situation. The upper centrals are slightly, not horrendously, but slightly retroclined. The lowers are actually reasonably upright, but they're getting constricted by the uppers dropping back. Bite is deepening a little bit. The choices we've got for this case are, number one, we can just do nothing. We can explain to the patient. You could actually also give the patient a retainer to stop the teeth getting any worse. That's actually an option as well. But if you do nothing and you identify this problem, you must explain to the patient that the problem potentially could get worse over time. Number two is you could do what most of the dentists around the world do currently. You could just restore it direct or indirect. But then you must accept the consequences of the teeth fundamentally continuing to move and then potentially the restorations breaking. Or number three, you can do what we're talking about here today. We can use some ortho, get the correct overjet, get the correct overbite if needed as well with ortho or through direct bonding. It may be that we can do simple ortho. It may be we need comprehensive ortho depending on the case. And then as mentioned, we can use edge bonding to improve that final outcome. So here we are currently with this patient situation, and ultimately what we've got now is a constricting envelope, because in this patient's chewing cycle, the lower incisors are too close to those uppers and that they're retroclined. What we would really like is this situation where the uppers are pushed forward, the lowers are just kind of uprighted and aligned, and that gives us space to then place those upper restorations, as you can see have been placed. Now, how do we decide where to go? Well, I won't go on too much into this, but ultimately in IAS we use this concept called the landmark tooth. As I mentioned, we're looking at the tooth as the most correctly positioned, it's the most upright, it's in the neutral muscular zone as well. The key point is I want to keep that bit the same. So here's my landmark point on the lower tooth. I'm happy to keep that point the same and everything else moves to that point. And very importantly on the uppers, there's my landmark tooth or point, and ultimately that upper lateral tooth, it may rotate a little bit, but it's not moving out or in. The main movement is coming from the other teeth, and that tooth will remain the same. So aligning the teeth then allows us to then get the teeth upright, which then gives us the room to place some direct edge bonding. I tend to use a method of edge bonding called the reverse triangle method. It basically just uses 2 layers, and it's a very simple methodology. I haven't got time to discuss that in this webinar today. It may be something that I'll talk about on another program, but it is something that we do teach completely in our APB course as well, so you know how to do it. Edge bonding might be essential for anterior guidance and treating wear, so you must not discount it. I do not want to finish my patients and leave them on dentine, that's going to wear and continue to wear. I like to have the gum lines correctly positioned, and if the teeth are short, you must then do edge bonding. You must not chicken out of doing edge bonding because you just want to pull the teeth or extrude them. That's my opinion. So here we are to begin with. Here we are now with the ortho done, pushing the upper teeth out and relatively aligning the lowers. Now we have space to place our restorative material, which we have done. This next picture is now 3 years later. The lower edge bonding has been done about 6 months after the beginning, so it's been there about 2.5 years, and that's actually technically what we call Dahl principal edge bonding. And the most important view now here is this same view at 3 years, the chin-up view. The upper edge bonding's been there 3 years, lower 2.5. But the most important thing is none of this composite's had to be changed. None of it's chipped at all. The patient's been really happy with this outcome. And here's a question. If we hadn't done the ortho, the patient wasn't wearing retainers, do we really think that this composite would still be here? No, it would have chipped like all the others had. But by getting the teeth in the right position, this has actually given us the best outcome. Here's the same patient at 5 years. You can see a little bit of dehydration. You can see a little bit of just rounding off of those lower composites. And yeah, they're rubbing down a bit. But this has now been here in total about 7 years, this case, and I still haven't replaced any of the composite for this lady. So, a controversial statement that maybe, perhaps, just perhaps, a significant proportion of anterior crowns were placed for the wrong reasons and still are today. How would I say that? Well, from the evidence that I've shown you, and the fact when I look back honestly at the work that I've done over the last 25, 30 years, I would say in the first 15 years, I think I've placed some crowns and veneers on teeth, and I didn't realize that this was happening. And if I had looked at those cases today, I never would have placed crowns and veneers on those teeth. I would have done ortho and then bonding. So, I did the wrong thing. But we learn from our mistakes and we move forward. And I hope that this is something that we all will do and look more carefully. Aim 4. We've got to treat our patients, treat your everyday patients, ultimately to try and prevent this long-term breakdown. So we don't really want to just be obsessed about cosmetic dentistry patients. We've got millions of patients sitting in our chair who could benefit from this treatment. And here's an example of one of those kind of cases. Patient with deepening bite, old crown. She didn't really want anything cosmetic when she came into me, this lady. She had some pain issues on some of her back teeth, and we'll talk about those in a second. So she came in with some broken amalgams, and actually I just sent her to one of my dentists. She had some perio and stuff done, and I sent her to one of my other dentists, and he did a kind of big composite on that tooth just to kind of get her out of pain and just to assess that tooth, which I think is still there. We fixed one or two other little minor problems for her as well. So she then came back in for checkups and reviews, and she started looking at the way her teeth looked. But on those first few appointments, I started to also talk about her tooth position and help her understand that actually her bite was actually damaging her teeth. And that was because the upper centrals were a little bit retroclined and the lowers were chipping. And these are the images that I showed her, and I explained that the two lower centrals are too far forward, the laterals are kind of too far back, and that they'll keep moving and colliding against the upper teeth, which I'll show you in a second. But ultimately, showing close-up images like this helps patients understand that what is correct and what isn't correct. talking about exposed dentine is very important. That dentine is 6 to 8 times softer than enamel, that it is stained more heavily. And when you show someone a picture like this and you explain that to them, they start to understand. This patient remembers that, 15, 20 years ago, 30 years ago, she had beautiful teeth. And over time, they've got more crowded, and over time, they've discolored. So, what can we do? If I explain this to her and say to her it's going to get a bit worse, she can start to understand that maybe this is something that I'll look at over time. So what did I do? Well, I explained the potentially changing tooth positions. So looking at her upper centrals, I explained to her that they were both drifting sort of inwards a little bit. They were retroclining. I explained that the lower centrals were drifting outwards as well. We, over time, recorded the amount of dentine exposure, and we looked very carefully at enamel chipping. So each time she came back in, we were looking at photographs, just seeing has it changed. Another thing we did was a regular fremitus check. This was really, really important. So we actually showed the patient the pressure of fremitus. Now, there's a way of doing this by putting pressure on the teeth. It's something we teach on our courses. But ultimately, by doing this every day on your patients who've got incorrect tooth position, it helps them understand and get a feel for whether a tooth is actually slowly moving over time. She also understood that she had a constricted envelope, that she understood that her teeth were, as they moved together, they were, or they crowded, they were getting closer, and they were kind of rubbing each other down, a bit like a pair of scissors. That's kind of often how we describe it. But the key thing here is that we just reassure the patient. I always say to the patients, look, this is slow, this is ongoing. We observe, we don't panic them. We do offer to monitor, which is what we did with this patient for at least 18 months. We could even retain the case, or of course we could treat. And this patient, after 18 months, chose to treat because she could feel that the lower central teeth were knocking against her upper incisors more heavily over that period of time. And that must have been because the uppers were retracting and the lowers were proclining. So, of course, as always, we do an ortho assessment. She's a class 1 case, and what she ultimately realised was a class 1 skeletal, but she had a little bit of class 2 molar and class 2 canine, but she was really keen not to do much ortho, was happy to have minimal ortho, but happy to accept a compromised treatment. And she did become more aware and concerned about the tooth wear and the aesthetics, just based on what we had talked about, just gently giving her a little bit of an idea of how her teeth were changing. This is the curve we set up on the uppers, so we were looking to push the upper teeth out. This is the curve we set up on the lowers, so again, we were holding those two lower centrals in the same position, bringing the laterals out, and that the space was created really by advancing those upper centrals. So very minimal upper ortho movement done here. Now, normally I'd have to say when I've got a crown that I'm likely to change, or which we were, I'd usually swap the crown for a temporary and move that temporary and then change the crown later. In this case, we didn't do that because we had so few aligners. We just thought, let's just use 3 aligners and just see if this patient was going to tolerate the treatment, which she did. And we pushed those upper centrals forward. And what we also did on the lowers was to use an aligner, actually an inman aligner with a combined expander, on this case, to actually upright the canines, create space. We used PPR detriangulation on the incisors to narrow those teeth up a little bit. And you see how these teeth start to align up. And then we started bleaching them a little bit as well. And then we did a little bit of edge bonding via the Dahl principle to open the bite a little bit as well. And this then also allowed the space for the anterior restorations as well. Posterior teeth settle the way they do with the Dahl principle as normal. So the full before and after treatment here on the lower look like this. You see how the canines kind of kick up and shift out, and the lower anteriors align and detriangulate, and the edges look better. And you'll see from this picture the bite opens. This next image is going to be with her temporary crown and some composites that have been not fully polished, but you'll see how the bite opens a little bit, and you can see a little bit more tooth as well. She wanted to retain her bridge on the upper right side, which we did. These are the landmark points we chose on these lower incisors. So basically we kept those positions the same, and everything else moved. And on the uppers, the midpoints of the laterals remained the same. We weren't really doing much with the laterals. We did a bit of bonding on those, and the upper crown was replaced there. And here we are now with our immediate result, top and right, and then the bottom left, we have 3 years on. And this is just our temporaries, and then you're going to see, hopefully, a picture at 5 years on, and you'll see a very small amount of minor tooth wear, in fact not tooth wear, but composite wear on that lower incisor. And then now we are here at 6.3 years. Sorry about this slight exposure issue with this photograph. You see a little bit of wear on the lower central, a bit more wear on the lower central, and a little bit on that lower left canine. But the way to think about this is, here we are at 6.3 years. It's not perfect, but I'd like you to imagine where these teeth would have been if we'd not treated them in 6.3 years. So if I go back to where we were 6.3 years ago, think about this picture 6.3 years on. So the work that you do by aligning these teeth, additive edge bonding, and whatever else you do, totally prevents any further tooth surface loss, tooth positioning changes, and holds the occlusion and guidance and all the rest of it in a much better position over that time. That's the logic of what we're trying to do. So I've got a lot of old cases, but I'm going to just show you a little selection of a few cases, and you can see how that kind of long-term effect works on patients and keeps their teeth how they should be over time. This patient I treated in 2005. Basically, we did some upper ortho, minor upper ortho. She was worried about her worn upper right lateral, didn't like that tooth was short. Fundamentally, our focus was on aligning the uppers, and then we did a little bit of edge bonding on the lowers, as you can see on that lower left picture, which is actually being shown slightly too early, but I'm going to leave it now. So what we did is we did the upper alignment first, and by pushing that upper right lateral out, it then created space, removed that constricted envelope to allow me to lengthen that upper right lateral. I then did the edge bonding that you see on that lower left-hand side that slightly opened the bite a little bit. And then you can see here she was 10 years later on, and just notice that the upper right lateral is still exactly the same shape, length. It's not worn down, it's not chipped away. When the patient opens her mouth, you can see the lower incisors all the edge bonding is still there, even my original mistake on that little mesial contact. The lower right central has actually drifted forward a little bit because we did ortho on the upper arch, but we didn't do anything on the lowers, and we didn't give her a retainer on the lowers at the time because she didn't really want to do anything on the lowers at the time. But it's interesting to see how, imagine this case would have looked 10 years on without doing this treatment. Teeth would have been darker, there would have been more tooth surface loss, and probably more crowding. So that's the logic of what we're trying to do. This patient I treated in 2004. It's a constricted envelope case. 2004, I didn't even know what constricted envelope meant, but ultimately I did understand a little bit on ortho. I was doing a bit of ortho, and I did understand the Dahl principle. And the patient wanted to change these two slightly odd-looking upper crowns or veneers she had, and she wanted to treat the wear on the lower teeth, and she wanted to treat the crowding, and that's exactly what I did. Now imagine this case untreated 14, 15 years on. But I'm going to just show you the immediate after in a second. So we aligned her lower teeth, we did some dull build-up edge bonding, and I replaced those 2 units. I have to say they're not great, but we replaced those 2 units. And then now you're going to see this patient. Now imagine if she'd not had the treatment, but here she is now basically at 15 years on. Upper units are all still there. You can see the lower composite is wearing down, and one's almost completely gone now. But if these teeth had not been treated, she would have been a lot more heavy on that denting. Probably, I would say 1 or 2 millimeters more tooth surface loss at a minimum, more crowding, more constricting envelope. Probably would have caused one of the upper teeth to either break or push forward. So that's the idea. Yes, this case is going to need a little bit of tidying up, but 15 years and no real change. And what did I do with this case? Well, that lower flattened spot that you saw, the way I dealt with that was to build 2 new upper canine platforms. That gave me the space to then restore that lower incisal edge just a small amount to then minimize the amount of composite removal I had to do. So it's fundamentally all additive. And these sort of platforms that you see on the canines, this is a real skill and good thing to learn, and this is something that we teach you how to do directly freehand on our ortho restorative day 2 of the ABB course. Here's a case, I'd call this a failure because this one I should have got the patient back faster. But you can see we did some veneers on this patient in year 2000, very nice patient. We took these, replaced, somebody else did these veneers. She had an implant temporary, and we replaced those veneers. She was very happy with what we did for her at that point. And then if I show you the retractive view, so here she was at the start point when she presented. Here she was. It's about a year after placing these veneers, and I'd done some edge bonding on the lowest. Something's already chipped. Now the real failure here was that I should have got this patient back more regularly, and I probably would have replaced this lower edge bonding at about 7 or 8 years. But in fact, she then presented at 2017. This is how her lower teeth looked, and I looked at that, and if I'd seen her 5 or 6 years ago, we would have saved much more tooth. As it was, we didn't need to remove any tooth, but ultimately I could still do a Dahl build-up again, and that's exactly what we did. So you'll see we did what we call Dahl recycle number 1. And being able to do these Dahl build-ups is absolutely critical in dentistry. I'm not talking a lot about Dahl on this presentation, but when you understand how to use Dahl and when not to, and how to use it simply, freehand and direct, it is, in my opinion, probably the most powerful tool in dentistry when you really kind of get your head around it as well. So maybe come along and look at that because it's really useful. Okay, aim 5, carry out a better daily examination that helps your patients understand those dynamic changes. This is what I don't think we do in dentistry, and I don't think we're taught this way, because I think we're taught to look at things statically. Not enough dentists take photographs regularly. Yeah, we all take the cosmetic pictures and we do this and that, but are we really taking occlusal images of patients every 6 months or every year? Not many dentists do this. So how can it benefit us? Well, one thing I'd say is that intraoral camera is hugely valuable. They remove all doubt. I have a digital SLR, of course I do. But if you ask me what the most important tool in dentistry was for me, it's this camera. Now, not this particular make. I've had this camera for 15 years. There's lots of other great cameras around. But what this camera did for me is it meant that there's no doubt in anything I ever say to any patient. And one of the biggest problems in dentistry, of course, is trust between dentist and patient. And the minute I bought one of these cameras, actually 23 years ago, that doubt would disappeared. Okay, so that's one reason. What it also does is it encourages discussion at every checkup, and it allows for long-term monitoring. And I'll show you what I mean. So every single checkup I do, every checkup on every patient, every 6 months or every year, we take a full series of images like this. So this is like my new dental chart every single time I see the patient. And what we will then do is pull up images. If something new has happened, we'll pull up images and we'll do these comparative shots. And, I warned the patient 2014 that there was wear on the teeth and that I was a bit worried about constricting envelope. 2019, the corner's broken off the tooth, and the patient's looking at these two images and saying, yeah, you were right, Tif, I see what you're saying. So this really adds value. It helps patients understand if things are going to go wrong, and if they don't want to treat, it puts the emphasis onto them. It doesn't make it your fault when it breaks. And then when it breaks, they can understand why they need the treatment. And you have not done anything wrong. You've not neglected anything. So these cameras are critical to be able to do that. Other things you can do, I'm only going to touch on a few little ideas here. As I say, photographs, very important. Tooth wear is really important to observe, measure, discuss the difference between dentine and enamel. Patients, if they have dentine, patients don't know what dentine is. They don't understand it's 8 times softer than enamel. But this is a comment that I'll make 6 to 8 times every single day in my surgery. Also, explain tooth position. If the tooth's out of position, explain that it's out of position and try and think, well, where's it going to go? Envelope of function, very important to explain. Obviously, this is only an online course, so we can't do any hands-on. I can't explain that too much. Also, Fremitus tests are very important to do. This is something we teach a lot on our course program. Look at the OVD, the tooth display, the depth of bite. All of these things are things that you can add to every checkup that helps patients build a long-term view of what's going on, rather than just, have I got a hole in my tooth or have I got gum disease? This is the mouth is a mechanical object that's slowly changing over time, and that There's little things that we can do to help to keep the patient looking as good as we can, functioning as good as we can. And yeah, this is a little bit from our kind of course, and what we're trying to do here is teach dentists who are looking at each other, helping to understand the concept of the envelope of function. You can see the way my hands are positioned there. This is something I will do in front of patients every day, 7, 8, 9 times a day, so that they can understand. Looking at the tooth position, is it likely to change? Checking the wear, checking the fremitus, checking canine width, testing the joint. These are things that I'm doing in my everyday diagnosis, and I encourage people who take the program to look on each other, look on their patients as well. And then, of course, when you're ready to potentially actually treat a patient, there's lots of little things that you can start to look at as well. Even if you're not actually going to treat the patient, I'd be thinking about, my everyday patients, if they want to have treatment, is this going to be a compromised treatment? Do they need ideal options? Which landmark points would I want to hold on to? What appliances would I actually offer this case? We look at things like the biotype. It's very important how thick or thin the gum is, because particularly with aligners, it's very easy to abuse that biotype. And with aligner systems, they like doing a lot of, they call it round tripping. They push teeth out before they bring them back in. And if you have a poor biotype, you could cause actual damage. So it's very important to look at that. And another thing that we talk about a lot is this thing called PPR. If you remember the case with the triangular teeth, PPR will help you detriangulate the tooth to make sure that you end up with a better final aesthetic result. So there's lots of little bits and pieces that you can learn and implement, after you take these sorts of programs. And what we often find people say is that they go back to practice and they're looking at patients totally differently. People say, I've never looked at my patients in such a different way, and we have so much to talk about now during our checkups. That's what we really want. So this case that you saw a little bit earlier, similar kind of thing. I've been talking to this patient for maybe, it might have been 18 months or even 2 years, I can't remember. But she's come in and explaining to her that, the teeth are moving a little bit and that she's got this envelope of function constriction. Did then decide she wants to have some ortho, happy to have a bit of a compromise. We scan her teeth. We set her teeth up with the landmark points. We get digital setup done. We evaluate the setup as I explained, checking the landmark points remain the same. We have the aligners made up for us. Very simple 4 aligners, right now. And the way I'd say this is that, if I can do 4 aligners now, I'd rather do 4 aligners now than wait 5 years and the patient needs 10 to 15 aligners. This is the thing. If you can help the patient to understand the benefit, it's easier for everybody. We go through the edge bonding process that we talked about earlier. And ultimately what we're trying to do in a case like this is to think about where this case would be in 5 or 10 years' time. And that very small amount of minimal intersective dentistry that you're offering is giving them something which is taking their teeth back 5 or 10 years and holding their teeth in this position for hopefully another 5 or 10 years and preventing sort of further damage down the line, making the whole case much easier to recover. Ultimately, anything you're replacing here is just composite anyway, which is a better thing, I imagine. What we're also trying to help you understand is to look at cases and visualize how things are likely to change. Looking at pictures like this and developing this skill to start to map out in your mind where the directions of movements are going to occur, where the interferences and the contacts are going to occur, where tooth thinning, chipping, wear, discoloration is going to occur, is something that really can give you massive power looking forward. And again, same sort of thing here. Patient with lower crowding, upper thinning incisors as well, repeated chipping front teeth. If I can see where the teeth are going to move, I can look at this picture on the left. I know those upper centrals are actually medially rotating inwards, because that's commonly what happens to them, and the lower centrals lower incisors are clearly spilling outwards. That's causing a constricting envelope. By aligning the case, that gives us a space to actually restore the teeth correctly with the correct thickness of composite, that then allows us to give the patient a better aesthetic result. By visualizing those changes, understanding where teeth are going to go, we educate the patient. They make the decision at the time that suits them. There's no pressure. You're not pushing the patient. The patients will then come back to you and say, I'd like my teeth to look better, but I can understand that they're actually chipping a little bit and wearing. So ultimately, you're doing something that's aesthetic and functional, but you're doing it for, I would argue, a more ethical reason, because the patient really sees the benefits in what they're doing. And this patient, as you saw, same patient you were looking at just then, a very common scenario, kind of inverted V on her upper incisors, eventually decides to have treatment done, and align bleach and bond. And there are people out there doing veneers on cases like that. So I would say to you, if you can do it with such minimal interventive treatment, and you're also straightening the teeth and fixing the underlying problem, if someone said to me which treatment is better, I'd have no doubt and say this treatment is better. That's what I would say. So IAS, this is who we are. You can go on this page and download a little bit of information about what we do. We are not an orthodontic company. We are a restorative orthodontic teaching company. That's important to say, because we want to make sure that you take your records correctly, you move teeth carefully and appropriately according to good occlusal principles. Yes, you need to be able to restore them cosmetically, but restore them for function and occlusion, not just for aesthetics. And our most important ethos and our most important mission really is to make sure that it's not just about sticking a retainer on, but you are setting the teeth up in a way, and you are taking the responsibility for the case to try and protect and keep those patients' teeth for life. So by doing this treatment, you're not just making them look better, you're helping them keep their teeth for life. That's the goal of IAS. We have a whole mentoring program as well. So when you take a course, you get mentoring included as well, which then means your cases are looked after. It depends what kind of course you take, but you'll always get one case included. And if you become a member, your cases are IAS cases that are then free. But ultimately, we have a growing team of mentors all around the world, and our goal really is to ensure that the dentists get the best outcome. We don't believe there is anything quite as comprehensive as the IAS mentoring system. The way that we, filter the cases, we say no a lot, and we really make sure that our dentists are practicing as safely as we possibly can make them. We don't want dentists taking on cases they shouldn't be taking on. That's our goal. You can find out a little bit more about our program. I'm hopefully be coming to the Netherlands in September, and I'm sure the guys are going to sort of tell you about it and what we do and how we do it. So finally, ABB, yes, it can be aesthetic treatment, and little bits of movement, a little bit of bleaching, a little bit of bonding can do an awful lot to a patient, and can stop that sort of changing tooth position in its tracks. But also we can be functional and preventative, and we can really reverse patients' dental breakdown. And the most important thing here is we can stop you having to pick up a drill and drill things down. And you know what, in today's environment and what we're in now at the moment, I think we've got to do everything we can not to have to pick up drills and generate aerosol and cut things and draw blood. This sort of dentistry is not aggressive dentistry. This is not surgical dentistry. This is all additive and minor movement. It really is simple. It really is simple. Obviously, you've got to think through it, but it's simple. And yeah, little over a long period, little impact. So here's someone, 2005, wanted veneers. So just interesting story to finish on. Wanted veneers. In fact, 2001 she came and wanted veneers, but she didn't have any money or didn't have enough money. She came back to me in 2005 after I'd started doing ortho. So I then convinced her just to have a bit of ortho done first. And actually, of course, once we straightened her teeth and whitened them a little bit, she then decided to have edge bonding. And this is where she ended up, and she was totally happy with this outcome. In 2011, we just replaced 3 very small, tiny little bits of composite on the edges of her teeth. And here she is at 2019 with only those 3 little composites replaced just the once. So 14, nearly 15 years later, her teeth are pretty much the same. How long do veneers last? Well, average lifespan apparently is 10 years. So you have to think about what impact, what dental footprint we leave on a patient when we do, ceramic work, arguably unnecessary ceramic work. And instead, if we can use the patient's own teeth and do additive work, can we be in a better position? Not always, but I believe in many cases we can. And for me, the interceptive approach is where the magic is. So patients with sort of collapsing bites, occlusions that are long-term sort of failing, if I can go in, align the teeth, improve the canine guidance and open the bite, I know that, here we are 11 years on with this case and the teeth is now starting to wear, and then we can just zip off the composite, replace it, and at 13 years, Dahl recycle number one. But think about where this patient would have been at 13 years with no treatment. This is really the goal. It doesn't look perfect. I'm not trying to. We're not trying to out. It's not a beauty contest. It's more about actually giving the patients real dentistry that's going to last, that real people can afford and real people can actually access as well. So, final message that I'm going to give you now, assuming it plays, is I believe that this lifetime approach is less risky and better for the patient. It's less risky for the patient, the dentist, and I believe it's better for the patient as well. I believe a little ortho restorative is essential in everyday dentistry or is compromised. I think every single dentist needs to do a little bit of ortho, and I would personally, I wouldn't go and sit in the chair of a dentist who couldn't at least do a little ortho, because if you were my dentist and your solution for my repeatedly chipping front tooth was a crown or veneer, I'd be out the door. And I hope you would understand that comment after watching this short lecture. And I'd also say that if you're going to do ortho, you must do it correctly. You must assess the patient properly and do it within your limitations, and be mentored if you're not sure what you're doing. Just don't follow aligner company's advice. Aligner companies are there to sell aligners. It's so important that you have a dentist helping you through your cases. It's really, really important. And I also believe that this is a kind of dentistry that we can all be doing. This isn't just dentistry for superstars and superheroes and really rich, private dentists who can only treat a very small amount of patients. This is for everybody, because actually this treatment's a lot cheaper. But I'll tell you what, it's just as satisfying, and importantly, of course, it's just as profitable as well. So it's something we could all be doing. So I am going to say thank you very much. I think that is my final slide. I'm going to say thank you very much, and I hope to chat to you on the questions and answers. If you've got any questions, you can post them there, or you can contact me at any point. Take care. Bye-bye.